I wear three hats. I work at the Faculty of Medicine, University of Peradeniya. I'm a thoroughbred Peradeniya. I'm very proud to say so. I studied there, did my internship, registrar, senior registrar, physician, now senior professor, and all that. So I'm a thoroughbred. I don't know how many of you can say so. Arinda, you're not. Are you? Yes. Okay. All right. So yeah, I'm very proud to say so, and glad to see some of my teachers here. And then the one in the middle, the logo is a South Asian Clinical Toxicology Research Collaboration that I give leadership to a group of researchers from around the world, and together we have published about now I think 600 publications, which are highly cited, and we have produced about 50, close to 50 postgraduates, both PhDs and MPhils, and of course Peradeniya teaching hospital that I do my clinical work. So we will be talking a bit about epidemiology of this problem, how to diagnose. I thought the audience would be mainly medical students and registrars. Didn't expect uh, seniors here, but anyway, so they'll also learn something from this. So we will be talking about how to diagnose this, and then we'll also talk about the management. So why are we talking about this? So psychoactive drugs it's become a serious problem in the world, and I think the hottest topic of this country over the last maybe few months has also been psychoactive drugs. They're discovering truckloads of psychoactive drugs, and so it could be either it was never imported to this country before, or they're getting imported now for the first time, and which I think the former must be the correct one. They were imported and went unnoticed, and they got distributed around the country. So if you look at the world figure, so there's this. This is a technical report about this psychoactive drugs, and this is about presentations of hospital due to drug related issues. And if you can see that the commonest, nearly 60-70% of all drug related or tablet related presentations of hospital are illicit drugs, psychoactive drugs. So we look at what the commonest agents are. These, heroin, cocaine, cannabis, GHB, and so many amphetamines, so many drugs. Heroin being the commonest. What about Sri Lanka? So there's only one study that is available about the epidemiology of psychoactive drugs. So this study was done in a rehabilitation center. Actually, it's a good place to study this. And cigarettes being the commonest, alcohol, cannabis, nearly 90% of the residents use cannabis. Heroin, about 83%, methamphetamine was 73%, cocaine, morphine. So the list is very big. And as I mentioned to you before, it is a growing problem. But the problem is getting bigger and bigger. So this, this I just purposefully picked this because it was in kilograms. It was in grams when we were students. It became kilograms. Now I think we detect them in truckloads. So this is a big problem. And those practicing in emergency units, medical wards, are bound to see more and more of these patients. So it's important that you know how to manage these patients. And what about how big a problem is this is data from United States. When we talk about deaths, the number of deaths from drug overdoses, especially psychoactive agents, is steadily increasing in the US. Um, we don't know what is happening in this country. We don't know. So we need to set up a special monitoring system to see how many come, how many die, how many, what are the morbidity, mortality, and all that. So we don't know about this. So if somebody wants to do a research project, and this probably is a good area because we, in terms of the numbers, I don't think you'll have to worry about this. Plenty of them coming. So psychoactive substances, there are classical psychoactive substances, and there are newer ones. So it's basically, if you remember this, that's all you need. There are three types of psychoactive substances. There are stimulants, depressants, and hallucinogenics. So those are the three classical ones, and so there are common names: ecstasy, amphetamine, cocaine, cause stimulation. Then there are depressants that get you to fall asleep, feel happy, opioids, benzodiazepines. GHB, though people don't know about GHB, I think it's very common in this country. There's this story where lots of newspaper articles saying I got into a bus and I met a person and I was offered a drink and I don't know what happened thereafter. So and they wake up in a few hours, they find all their belongings gone. So that is that, though nobody has reported it, that must be the agent that they use, which is a colorless, tasteless liquid, and that gives you a nice sleep. And something special about this is that you don't know what happened. So it's used as a date rape drug in the West. You meet somebody who offer a drink mixed with usually gin, which is a white. Arinda says gin is white, so it probably is white. So it's a white color like water. So and it's mixed. It's GHB. It's mixed into this, and then the woman is raped and wouldn't recall anything about the event in the morning. So it's called the date rape drug. I'm sure it is available in this country. Then there are hallucinogenics like classically ketamine and LSD. So now these are the three sides of the coin. So I don't know what you had in your mind. The stimulants, depressants, and hallucinogenics. These are the three sides of the coin. So all you need to do as practicing medical officers is to classify, okay, my patient is now with a stimulant overdose or a depressant overdose or a hallucinogenic overdose. Those are the only three words you should remember. At the end of this talk, if you remember these three words and how to manage these three, you don't have to worry about anything else. Now, so stimulants, all of them present the same way. There's a long list of stimulants that are available, but all of them present the same way. They present with agitation, aggression, psychosis. They are big pupils, sweating, bruxism. Some of them, in worst cases, they get convulsions, hypertension, tachycardia, sometimes arrhythmia, chest pains due to coronary vasospasm, hypothermia, leading to sometimes rhabdomyolysis, acute renal failure, and DIC, and sometimes strokes, like hemorrhagic strokes, thrombotic, usually hemorrhagic strokes. So if you have a patient who is agitated, who is hypertensive, tachycardic, hyperthermic, you're most likely dealing with a stimulant toxicity. So that's all you need to know, because the management is the same whether it is D, A, B, C, or D, or E. It doesn't matter. So all you need to know is to identify this syndrome. Okay, this could be that, and then manage accordingly. And how it does is it's like pumping adrenaline to somebody. It causes activation of the sympathetic nervous system, but through various means. So pumping adrenaline, if you remember adrenaline, pumping adrenaline, and noradrenaline, that's exactly what happens to them. And probably the much larger doses. Sometimes you have these body packers who transport cocaine from one country to the other, and they pack them in their gut, and sometimes accidentally they rupture, and then it releases large doses of cocaine, and then they're brought in hypertensive crisis. And always remember to do a chest X-ray and get this history uh, to see whether whether the packs are there, and then the treatment is different. So management, as I said, whatever the agent is, it's easy, or not easy. It's very streamlined. Manage agitation, psychosis. You need to put them in a very quiet, dark place, a reassuring atmosphere. Don't ask them when the gut thing, why did you take this. Don't ask these judgmental questions. Said, okay, we know what's wrong with you. We're going to treat you, and reassure them. It is so important to keep them in a very calm, quiet, dark environment. And the treatment here is benzodiazepine. You need to give benzodiazepines. That's the treatment. So agitation and psychosis that they present with is treated with benzodiazepines. So remember benzodiazepines. And another disturbing problem is very high blood pressure, 200, 250, very high blood pressures. Again, the treatment is not antihypertensives, but benzodiazepines. And if they complain of chest pain, and the best drug would be a nitrate, intravenous nitrates. You need to avoid beta blockers to bring the blood pressure down. Can any of the registrars tell me why? The reason is that these act on both alpha receptors and beta 1 receptors. So beta blockers block only the beta receptors, and these alpha receptors are waiting. So they are unopposed alpha action. All these then they act on the alpha receptors, and you can get a catastrophic rise of blood pressure, hypertension, hypothermia, and all that. So it's so important to make sure that you don't give beta blockers if you suspect this. So if you're giving, you need to combine with an alpha blocker and give it. So the best way to manage hypertension is benzodiazepine and nitrates. So the third problem that you have in stimulant toxicity is hyperpyrexia. Their temperature go very high. They bake themselves virtually. It should be considered a medical emergency, and you need to bring the temperature down very quickly. And packing them in ice brings the temperature down quite rapidly, about 0.2 degrees per minute. And you can use many methods. You can cool them, spray them with cool water, endovascular, various things. Again, benzodiazepines is the treatment. So for any syndrome that you have a patient who is suspected of having stimulant toxicity, the drug of choice is benzodiazepine. Sometimes you have to paralyze them and ventilate them, and so we also sometimes use ciprofloxacin, which we'll talk about it later. Now there is this. This is an elective medical student. I just saw two, and I thought changing, tourists to elective students. 31, presents with state of unconsciousness to the ED, and he's found a pinpoint papers, pulse rate of 78, blood pressure slightly low, sats are low on presentation, but even with oxygen, it maintains low. So what might this be? Any thoughts? If this was a farmer coming from Polo Narrow, what is the diagnosis? Of course, phosphorus insecticide poisoning. But if he's a tourist, it's. So you can see that this patient, everything is depressed. GCS is depressed, pulse, blood pressure, everything is depressed. So this is the other side of the coin that you deal with, the depressant. So the other end of the coin, basically. So this is a very common presentation, and What would you do to this patient now? Yeah, I mean, what do you think the diagnosis is? Opioid overdose. Yes, opioid overdose. Yes, he's had a bad trip. Yes, they call it a bad trip. Yes, so you take it too much and you become very sleepy. And then the treatment is you give a trial of naloxone and see what happens. Yeah. So I think you need to know a little bit more about naloxone, how to give naloxone, when to give it. So I mean, if you're working in the ED or medical area, somebody coming with these symptoms, it's worth give a trial of naloxone, see if the patient gets better. Uh, it is a competitive opioid antagonist, so it acts very quickly, and you give it, you should see the result at the end of the needle very quickly. You need to give titrated doses between 100 to 200 micrograms, repeated every 3 to 5 minutes, and see if there's a response. Some people give larger doses, and you must make sure that you don't give more than 10 milligrams. That's the maximum permissible dose. You give it IV. If you have no IV access, of course, you can give it IM as well. And then when they get better, if there is a response, yes, you know that it is your diagnosis is correct. It is an opioid overdose, and then you need to give repeated doses until the patient becomes manageable. Don't give it to make a GCS of 17 or 18. Manageable GCS or maybe 12, 13. The patient is breathing okay, and then otherwise they get up and run and cause havoc. So, and then if you think that the patient needs continuous infusion, you need to give uh, a smaller dose. Usually, what the dose given is two-thirds of the initial dose that the patient showed a response as an hourly infusion. So this patient that you got, there was no response to naloxone. So given titrated doses, you give escalating doses, total dose of 2 milligrams. There's absolutely no response. What are your thoughts at this point? Any thoughts? The differential. I mean, it could be, sorry, alcohol. Yeah, benzodiazepine, alcohol, benzodiazepines, gabapentins. There are newer recreational drugs. Could be a new one. Uh, Other CNS depressants, somebody mentioned, it could be a medical cause, like a brainstem stroke. Uh, so how do this depressant, that's mainly um, increasing the activity of GABA, and also acting on the opioid receptors. So at this point, you might want to know what is it. So this looks like an opioid overdose, no response to naloxone. You're more or less excluded other causes. So what are your thoughts at this point? Might want to do some investigations. People turn to what are called drug screens. A drug screens, though it is practiced very popularly, they are very little use, very little use. So drug screens, especially urine dipsticks, are of very little use in diagnosing. There's ample evidence that they only mislead. So your clinical judgment is the best. So what about this patient? So don't transfer patients. Okay, we don't have drug screening. Send this patient to the next hospital. Don't do that, because that hospital will also not have, and it will be of very little use. So this patient, you have to think of GHB, which I introduced it to you briefly. It came initially as a bodybuilding agent. Now it has become a very common drug, psychoactive drug that is abused. It's also, as I mentioned, it's used as a day trip drug, and I think it is. I'm just showing this to you because, though you don't think it is in this country, it is there. It is there. We have seen enough reports of people being robbed here and there after having taken a very nice, after having taken a drink somewhere. So, like in all the central nervous system depressant agents, the management is purely supportive. Um, Even for benzodiazepines, the other depressant drugs, other than opioid overdose, is supportive care, management of the airway, breathing, and most of them have very short half life. You manage the airway, breathing, blood pressure, and when the half life goes, below 3 half lives, they get better and they go. So you don't look for antidotes all the time. So one thing special about the GHB is that uh, they sometimes they revert to withdrawal symptoms because it when you keep on taking it upregulates dopamine receptors, and when the levels go down, uh, they can develop withdrawal symptoms. They can become agitated, psychotic, and you have to manage that with again benzodiazepines. So all of the depressants are managed symptomatic and supportive care. Fluids, airway management, and very rarely, you might have to intubate them. If your GCS is very low and if you think the airway is threatened, then you may have to intubate for a short period of time, and then they get better and go. The third side of the coin is, of course, the hallucinogenics. So they get all sorts of hallucinations, visual, auditory hallucinations. They become euphoric. That's why they take it. They get sensory distortion. They start seeing and feeling things. And if you examine them, you might find them sweating, tachycardic. Sometimes they're dehydrated and get a dry mouth. So how do they act? They activate all these things have different action, but commonly they activate the 5-HT2A receptors, and there's this thalamic filtering. There's a place in the thalamus that filters all the nonsense information, and it affects that. It impairs its function, and then there's this center called default mode network. The psychiatrists might know. It is involved in self-referential thought, mind wandering, and person's sense of oneself. So this is distorted, and you start seeing funny things. You feel you're like, yeah, I'm the president of this country. I can do this. I'm the god. I can do anything. That sort of thing. So it takes you away from reality. So these agents either inhibit or activate these centers and give you this hallucinogenic state. So again, when you're managing patients who come with hallucinations, you have to think of a possible overdose or with a hallucinogenic agent. How do you manage them? Again, there's nothing very specific. As I told you before, you have to address immediate life-threatening situations, airway management of the airway, because some of them can have a threatened airway. Again, as I mentioned, you have to keep them in a very calm environment, absolutely calm, no sounds, nothing. And then you have to manage the symptoms. Again, benzodiazepines is the drug of choice in managing most of these patients. Fluids, managing airway, and that's all. You need psychological support and the usual stuff that you do. Any questions so far on those are the classical ones. Then there are new psychoactive substances. They're called NPS. There are so many of them. So what is a new psychoactive substance? What they do is they're very smart. The drug world is so smart. They change structure of existing molecules. Tiny change here and there. And then you get a new substance and it acts differently. And the most important thing is that those people who the the well, the police or the drug agents that work against drugs, they can't detect them. They evade testing because of this change structure. They not be detected in routine screening. So that's why they keep changing. Um, and this is a good example how it is changed. One of them, and it's a very there's serious business there. It's very rapidly evolving, and it's so important to know that this is happening. You may see newer ones coming each time. So just to give you some example, there are synthetic cannabinoids, new benzodiazepines, new opioids, and it keeps happening at an alarming rate. So this is a report from the West. You can see that these are the number of new agents that have been detected. So 209 cannabinoids, 156 cathan. So many things. So how can you keep pace with this? There are new agents, some variation in symptoms. So they're manufactured usually. There are some smart people who this is their trade. So they change these molecules and they produce it in bulk and they get exported to other countries. And they're shipped because they evade detection by routine drug testing. They are sent as white powder, washing powder, various things, and that's how they find uh, their way into countries, especially where the law is a bit lenient. This is just to show you how cannabinoid structure evolved over the years. You can see it keeps evolving every few years. So this is the case with everything. This is just cannabinoid that just I showed you. Something you need to worry about it. Sometimes they may not have the expected clinical signs and symptoms because of the changed in the structure. So you have to be. I've given you two examples. You have to, they give different signs and symptoms. So you have to be slightly worried about it in a few cases. So just to take you back, this is the classical recreational drugs, that the three sides of the coin: stimulants, depressants, and hallucinogens. And these are the novel psychoactive substances. So there are quite a lot of them. Now you might be wondering how they have to deal with all these. You see so many things. So how do I manage salvia, for example? How do I manage the novel benzodiazepine overdose? Some of these you can't even pronounce their names. So how do you manage all these? It's very simple. You don't need to worry about what agent the patient has taken. You need to treat the patient, not the drugs. So we know how to manage a stimulant overdose, benzodiazepines, cooling, managing other blood pressure, hypertension, all of that. Depressants, mainly managing airway, and supporting hallucinogens the same way. So though they are newer ones, they're in majority of the cases they act more like the classical one. So you don't need to worry about these things. All you need to find out is which syndrome the patient has. Is it a stimulant syndrome, hypertension, agitation, psychosis, hypertension, tachycardia, increased temperature, or depressants, reduced GCS, low blood pressure, bradycardia, threatened airway, or hallucinogens. So that's all you need to know. So yeah, again, just to say, listen, manage the patient, manage the syndrome. Is it which one are we dealing with? Don't worry about the names. Just look at what the patient looks like. Which syndrome does the patient fit into? Hallucinogen, depressant, or a stimulant. I keep repeating these words because that's all you need to know. You need to know at the end of today's talk. So conclusions are very simple. I think I've concluded. You need to worry about the large number of new agents that keep coming, but you need to be aware of it. But I don't think you need to change your practice. You may get an odd drug that changes differently, but most psychoactive substances present in the three ways that I told you about. So again, remember three things: benzodiazepines, nitrates, oxygen, airway management, fluids, supportive care. Sometimes you may have to give naloxone if you think it is opioid overdose. I think that's all I have to tell you. Again, treat the patient, not the drugs. Thank you. Or treat the syndrome, not the drug.
Right. So, thank you very much, Prof. So, first question from me: where can you buy these?
Well, the answer is very simple. The answer is very simple. Now, I don't know whether you're driven to say, for example, the dry zone. You go with the driver, yeah, and you ask, can you get Valbo for dinner? And the driver will get it for you. But the people know where they are. Yeah, I mean, there's this, I don't know, subculture where by you go to a shop and but the vendors know how to judge your body language. It's after this. Here it is. It won't be difficult. But you won't get anything dressed like that. Arinda, you need to look a bit.
Yeah.
I also do. I
Any
haven't mastered it.
questions? Yeah. So, any question from? So, yeah, I think it's like legally certain drugs. It's if you get caught with it, you are legally they can.
Yeah.
prosecute,
Yes. Of course. I mean, yeah. I mean, there are different laws for using it and selling it.
selling.
Yes. So the punishment in this country is so harsh. Yes. Yeah. Of course. That's one of the commonest drugs that people get addicted to.
And yes, so sometimes people come, especially the minor stuff.
Yeah.
Come
It pains. To
to
get
get pain.
pain. Yeah.
I think they take it and they go and sell it.
It's not available. It's not available as an isolate. It comes in paracetamol. We can't buy it now. Yeah.
Codeine we don't have it, sir.
No, we don't
Or
have
they
it.
take the cough suppressor. There's a small amount of codeine, Paradine, but that's very small. But if you take codeine per se, that's 36,
Yeah.
Here, Paradine is small amount.
Very small amount. Yes.
And cough suppressor.
So don't worry. You can't get a high on that. Don't worry.
So any other questions? From the registrars?
So three syndromes. Sorry.
Thank you, Prof, for very.
One more question.
Yeah. Sorry.
Ayurvedic philosophy selling something
More than I think they are. Yeah.
what does it contain?
I think it contains ganja, cannabis.
So now, because as we all know through the media and also with the exposure, like it's a very common even among the school children.
Yeah.
Especially and also the other part is the sports people.
Yeah.
So we have like very strict rule when it comes to the sports stimulant and all these are under the prohibited drug list basically. So we have a very strong action against them, but it is in the parliamentary act as well.
Okay. Yeah.
So what I want to know, when patients come in the toxicity, so when you come across these patients and treat in the wards, so even when you detect, so this kind of a stimulant is being taken and is in acute condition as we've been already treated and let's say now it's going out. So what is the next action? Like, are we as medical doctors, do we have any kind of a legal bond to release this news or the information to the authorities and do any actions, or what is the picture or the statements at this point?
Yeah. That's a very good question. When you were house officer, you remember we had to report all self-poisoning patients who come presented to us with self-poisoning had to be reported to police. And now that is not there. I'm not really sure, but no, you don't have to do it. You don't have to do it. It's a patient's autonomy. No, you can't. No.
There is definitely a medical legal aspect.
No, not in recreational drug use. No,
Suppose
you violate you.
suppose if a patient comes with some acute situation where you suspect that he or she has taken overdose of one of these things, shouldn't we inform the police?
No. It is. You could be sued for disclosing what information against his patient's will. It's about patient's autonomy. There's no legal, as far as I know. As far as I know, there's no legal. You are not bound to report.
Inform the forensic pathologist.
No, unless somebody says I was poisoned. Yes, then it's different. I was given this drink on the bus. Then yes, but no, not otherwise.
Can you refer them to the psychiatrist?
Oh, that of course must be done. I only discussed the acute matter. Yes, you have to do that. You have to do. You have to refer to the services to get them off the hook. Yeah.
By legalizing cannabis, like in US in certain states, whether you can cut down other more dangerous drugs coming in. By legalizing cannabis, like in US, in certain areas. I mean, this is not a political thing. I know.
But humans, being human, they like to experiment. I mean, you try this, so you get okay. Now I need something bigger or better, and they go to another one. So that's the nature of the humans. So they'll always look for something bigger, better. So I don't think that will do it. But it'll legalizing. It'll make cannabis, of course, cheaper, and I think so.